Hi, everyone. Welcome to today's webinar, Outpatient Procedural Coding Changes and Their Impact on the Coding Process. This is Sharon Byron from TrueCode, and I want to thank everyone for taking the time to join us today. I am happy to introduce today's presenter, Karen Scott. Karen is a senior training specialist with TrueCode. A lot of you might be familiar. She does lots of webinars for us. She's also the president of Karen Scott Seminars and Consulting. For those of you who aren't familiar with Karen, she has lots of HIM experience. She's worked in consulting. She has taught at the university level. She's written textbooks, worked in acute care hospital setting, and she's also past president of both Tennessee and Arkansas Health Information Management Associations. So we're thrilled that Karen's presenting for us today. And before I hand it over to Karen, I just wanted to review a few things about how the webinar will work. So everybody is in listen-only mode, which means you need to use your control panel to communicate. Your control panel is on the right-hand side of your screen. You can minimize it to see your screen better. You can do that by clicking on that little arrow that you see on your screen there. If you want to ask a question, you can do that in the question section of the control panel, and that's towards the bottom. To ask a question, just click on the little plus button. That'll open up a text box. You can type your question in there, and then we'll respond most likely at the end. I'll be monitoring the questions throughout, but we're going to hold questions till the end. And whatever Karen doesn't get to, we'll try to follow up with you if we can. There's also handouts for today's presentation, and those are accessed in the handout section of the control panel if you would like to use those as a reference. They were also emailed out about an hour prior to the webinar, so you may have been able to print those out in advance. And lastly, I want to make sure everyone receives their CEU. So we'll be sending out an email first thing tomorrow morning that will contain a link to a brief webinar evaluation. So you just need to submit that evaluation, and once you do, you'll be able to download your CEU certificate. If you have any questions, you can always send me an email and I'll make sure to help you. And there will also be a URL at the end of today's presentation with that same link to the webinar evaluation. But if you don't copy it down in time, don't worry. We'll be sending an email out with that link. So just sit tight for that. So if you have any questions, feel free to send me an email. And with that, I'm going to hand it over to Karen. Thanks, everyone.
Thanks so much, and welcome everyone, and we're happy to have you back for one of our educational sessions. So we are just sit back today. I've really got a lot of information to give to you today. I've got my CPT books and everything right by me, so I'm going to be flipping through that today. Just remember that all codes and their descriptions, everything is copyright protected. Everything we're talking about today is basically my interpretation, looking at the changes and talking about how they might help you and looking at them from a coding perspective. So hope you will find it helpful. The handout today is really the whole entire book. We won't have time to go through all that, all the little changes. I'm not going to go over all that. I'm going to really kind of try to focus on the bigger issues today. So I may be skipping past some screens that you see there. So here is the overview of the changes today. And so you can see there that it does give us all the information about the changes in the different chapters. Not quite as many this year as we see some years. Not a whole lot stuff going on in the evaluation and management section. Just a couple of new codes there. Nothing in the anesthesia section. Quite a few surgery codes. Again, not as many as we see some years, but we did see some new surgery codes, some revised, and then some deleted codes as well. It's interesting that we're not seeing quite as many revised codes as we used to, and that is because if you remember, when there are big significant changes to the code description, instead of just revising it like they used to and putting the triangle out there, instead, if it really changes the way that we're using the code, then they are instead just deleting that code out and starting over. And that really does ease some of the confusion that we have had in the past when we had a code the year before and its description changed dramatically, and so then we're not sure how to use it. So that causes a lot of frustration with the system. So I kind of like the fact that they're not doing that quite as much. So the revised codes are really going to be things that just a couple of things, or maybe maybe separating some codes out, that kind of stuff. Typically, you'll see some revised codes along with new codes because they've divided maybe one code and they've divided it out, or they've turned it into a parent code with an add-on code with it or something like that. We'll probably won't have a lot of time to talk about radiology and path lab today, but you can see there are some changes there. And then in the medicine section, 47 new codes, 10 revised codes, and then a couple of deleted codes there. A couple of things added in category 2 codes for those of you on the physician side, and then category 3 codes. Most of those we will cover those new codes as we go through the surgery section, because there's quite a few new category 3 codes that really do go along with surgery codes. They really are surgery codes. They just happen to be in the category 3 section for now, but we do always see those change over time whenever we have a code that is used so much that they feel like it needs to be deleted from the category 3 section and moved over into the main section of the book. So let's move on and let's talk about some of those changes. Let me see if I can get the screen to move forward here. There we go. So one thing that I wanted to point out to you in the introduction, they've just really gone through and done this throughout the book, reminding us that all of the add-on codes are exempt from using modifier 50. So in the introduction, there's actually even, and I'll talk about this in a little bit, but in the modifier section, there's actually a modifier update. Just the definition for modifier 50 is just a reminder that you would never use a modifier 50 to the add-on codes. So you will see notes with a lot of the add-on codes, a lot of the new add-on codes this year. You'll see notes underneath them that says, if this is done bilaterally, don't use modifier 50, code it twice. And that's kind of a weird instruction for us, but again, it's because they're add-on codes. So I'll show you a couple of those. You'll see those in some of my notes, but just wanted to let you know that as well. In the E&M section, a couple of things there, not a whole lot of new things here, just some little notes there, again, because when they delete out codes, they have to change every note, every instruction, every cross-reference that's anywhere else in the book. And so you'll just see as you, and that's typically what I do is when I get my new book, I just flip through every page and I look to see what's new this year. And so a lot of those are just a change in the description or in the instruction because of codes that were added there that are maybe gone, or they've changed, or they needed to add some more in there. So watch your codes. If you're doing any E&M, watch those that are time-based codes or can be used with other things like oversight codes. So you just want to be careful with those and just watch your notes there. Excuse me. Same thing with a lot of the non-face-to-face. They're just trying to give us guidelines in a lot of these codes where the patient is not being seen as to the time limit, or how often can I use this code, or what if I just saw the patient and then they have something else going on the next day? Can I also use these codes? So just watch those codes with caution. Like in the telephone service guidelines, it just tells us you can't use it within 24 hours of seeing the patient, or if you're going to see the patient at the next available acute appointment, then you cannot use these telephone codes and get credit for them separately. Those then become really pre-service work to the visit that's going to be face-to-face. And you also can't use them within 7 days after a visit or in a post-operative period. Again, that's just part of the overall taking care of the patient. So you just want to be really careful in looking at the guidelines for those non-face-to-face as far as how often, what is the information on how I can use those codes. The new codes in this section are the online digital evaluation and management services codes. And if you're keeping up with those, you can look in your code book, 99421, 99422, and 99423. Those are the online digital evaluation management services. I love the fact that as we're seeing more patients contacting and communicating their clinicians on a basis other than being face-to-face, that we're giving the doctors a way to get credit for that. And many insurance companies hopefully and are starting to pay for these more. But basically, these are actually their E&M services, but they're online. And these can be like online, these can be through the portal, however is the good way of communicating with that physician. And it could be whatever is appropriate, HIPAA compliant, you know, all that information is there in the book. There's also very specific time frames with these. Again, how long has it been since we've seen the patient? How long before we expect to see them? Or if we do expect to see them or do see them, then we can't, you know, we may have to look at if we've coded something in that 7 days. So there's a big 7 day there. It says basically you're going to add up time over a 7 day period. And it begins with the physician's initial personal review of that, and it goes through all the information that has to go into it. So it's not just one response. It's actually the whole entire evaluation and management. It includes the writing prescriptions or calling the prescriptions in or electronically sending those to the Walgreens or whatever. It includes all of the work with staff or ordering tests. And also at the end of that, it does, you got to have some kind of end of that conversation, basically, or what are we going to do next? What's the plan, the treatment plan for this patient, just like if they were on the site there. Again, also that 7-day rule is really big, because you're adding together the time, but then also it says if within 7 days of the initiation, a separately reported E&M service occurs, then basically that's all going to be incorporated in those services. So you got to be careful about when and how you report those. So those are good, but again, you want to be super careful. They also have added in over in the medicine section new online E&M for other types of providers other than like physicians or nurse practitioners, like when you have speech language pathologists, physical therapists, those kinds of people as well. There are new medicine codes for the non-physicians for the same types of services. So that's good to know as well. And I think that's really the biggest things. There are some remote monitoring with patients. When you are remote monitoring, there's so many things now that we have, Fitbits and other types of electronic devices. Of course, it does have to be an FDA approved medical device, but there's lots of times we can monitor patients and we can use that information to treat them. So they came up with codes for those evaluation as well, because again, there are kind of a E&M type of a code there. And then all of the care management services toward the back of the E&M section, all of those have been basically just the notes there to remind us about when you can and cannot use those in conjunction with any other code. So that's the basic stuff in the E&M section. And again, I'm going fast to this because we have a whole entire, book to get through in this little bit of time. And most of you are probably ready for surgery codes anyway, and so we're going to go right there. So the first area we're going to talk about in the surgery section is, of course, the ones or the integumentary system. Remember, they made a lot of changes last year with the fine needle aspiration biopsies as well as regular biopsies. So I've seen a lot of issues over the year, people not using those correctly and the documentation. So they didn't change them this year. I just want to remind you that I'm seeing a lot of issues when I'm doing audits out there of those codes that change pretty dramatically, like the tangential biopsies and the punch biopsies, and how to use those codes appropriately. So I would definitely be careful with all those as well. What I want to look at is the repair codes, and the repair codes are found just after the excision of lesions. And the repair codes are over with codes starting at 12001. If you want to make a note to go back when you get your new code book in, if you don't have it yet today, I'm looking at page 89 in the professional edition of the book. So they redefined, we've had simple, intermediate, and complex repair of the any kind of suture or wound repair over the years, but they've defined those and they've honed in a little bit more on your intermediates and your complex repairs. And so remember that a simple repair, which did not change, basically talks about it's a superficial wound, primarily the epidermis, maybe a little bit of dermis, the subcutaneous, but there's no significant involvement of deeper structures. The intermediate repair is where they have to go down into the deeper layers of the subcutaneous tissue and the superficial non-muscle fascia. So that's something that's really important. It's not just a layered closure. Be careful of those definitions. Intermediate, they have to document something about the fascia. Again, that's not new. What they added in, they also said this year that it does include limited undermining. And there's even a picture in the book, because in the way that they've defined these is undermining is going to be either under intermediate or complex repair. Now, what is undermining? I went in and I looked because I wanted to know exactly what that means. And basically, if you have a wound, what undermining is when there is like if a wound has to be debrided and they're sewing it up, or there's all kinds of gunk in there. Basically, what happens over time sometimes as wounds maybe don't heal properly, the tissue under the wound edges becomes eroded, like underneath the edge. And And so it results in like pockets beneath the skins at that wound edge. And the way they measure this is they actually can put like a little probe underneath the opening of the wound, and they push it until they get resistance. And that's how they measure. So they're measuring is how deep is that undermining. If that wound has eroded away, the edges have eroded away pretty far, then that can move it over into a complex repair. If it's just a limited undermining, and it even gives you the definitions there in the book, then again, that would be at the intermediate repair. So if that's a new term for you, you might want to look it up, go do some more. Again, you can just go out on the internet and look, or you can talk to your clinicians, talk to your dermatology or your plastics, and talk to them and say, okay, tell me what that means. What are you going to say? Are you using terms like undermining? What types of wounds would we see that on? Because again, that can make a difference in the actual code definitions and which ones you can use there. So I love the fact that they do give us these pictures that help us be able to find those codes a little bit better in the future and in the code book. All right, the other thing that they've added in this area are some of the different grafting codes. So if you want to look over at code 15969, for example, these are all new this year. And what they've done, this is under the other flaps and grafts, and they have given us different codes with some of these different, we have all kinds of biopsies and harvesting. Well, this is harvesting of soft tissue, and they define soft tissue as being anything like fat, dermis, fascia, or other soft tissue. And when it's harvested from that patient, that is going to be auto, AUTO, anywhere you see that, autologous, autograft, anything like that is going to mean that they're getting it from that patient. The methodology of how they're removing that particular soft tissue is important here, because if they're doing that through a direct excision, so they're excising the fat, the dermis, or the fascia, if they're excising it to move it and maybe put it into a wound area to fill it up somewhat, that will be the 15769. But all the new codes in this area are going to be over when the methodology is liposuction. So that's only going to be the fat. So when they do a grafting of the autologous fat harvested by liposuction technique, notice in these codes, it does have the site, and the site that they're referring to is where do they put it at, not where did they take the fat out of, if they took it out of the buttocks or the hips or wherever that may have been. It's where they put it into. So when it says things like liposuction technique to the trunk, breast, scalp, and arms and or legs, that's where it's going to. And notice it is 50 cc's. That's the measure between the main code and then the add-on code there. Okay, so again, the where they're sending it to, inject it into the recipient site, very important there as well. So we want to make sure with those also. Now, if you look over on the next thing is the code 15777. Just look at 15777, for example, in that same area. And this is where I wanted to show you, and I'm just going to show you at this one time and not really draw your attention to it later on in this program, because it really speaks for itself. And you'll see this a lot. And it was just when I was talking about with the modifier 50, notice under code 15777, it's an add-on code. I know that because it has the plus sign in front of it. It's got that particular code underneath it. It says, if they do this bilaterally, report it twice. Do not report it in conjunction with 15777. So basically, it's saying, hey, do this twice. You can put left and right if that makes a difference there. But basically, that's just different. I'm always thinking about bilateral always means use modifier 50, but not on the add-on procedure. So again, that's something just to remind us about within these codes. Now, they also went into the last part of this section of the book. They did go into the breast procedures and they cleaned it up. They wanted to make it really look like, what do we do now? What are the normal types of procedures? And they have changed breast procedures over the years. You're seeing a lot more people getting with our breast procedures. If they have breast cancer, they may be more likely to have a lumpectomy, which is a type of mastectomy, by the way. and instead of having a full mastectomy. But they did go in and they've given us really good definitions about what do they mean by percutaneous image guided breast biopsies. And then they give you also information about what do we do if they have a breast biopsy and on two different breasts. Again, how do I code that? So there's notes in this section under the definition of the percutaneous image guided breast biopsies. It basically says if they do more than one, you have to know the same, what type of modality. So in other words, if they're doing one breast biopsy and it is done with ultrasound, and another breast biopsy, they're doing it with stereotactic guidance, for example, or mammogram, then you're going to have two different primary codes. But if they do a second breast biopsy with different, with the same exact, it depends on the same modality. Now I'm trying to confuse myself, but basically, if it's a second one with the same modality, then you're going to use an add-on code for the second one. And it doesn't matter whether it's in the same breast or the other breast. That's the important piece there. If it's different modalities for that second one, again, same thing, whether it's in one breast or the same one. If they do the second biopsy with a different modality, like ultrasound as opposed to mammogram, for example, then if it's different, then you have two separate primary codes. So watch those notes carefully, because again, I tried to confuse myself when I was trying to read it to you or try to explain it to you. So make sure that you do go in and review those notes and make sure you're coding those correctly. When do I have two separate primary codes and when do I use an add-on code there? They also have instructions on like open biopsies, percutaneous biopsies, if they go in and put in a marker first, like sometimes when there is a radiology procedure done, they may go in and put in a localization clip or something to draw their attention so they can go back and find it again. Sometimes those little breast tumors, especially if they're in the ducts, they're tiny, they're little bitty. So they put in those like a little metallic clip, for example, in the spot where they can see it on radiology so that when they come back, they can get to it again. Or if they do a biopsy later, they can get to that biopsy. Or if they remove the lesion later, they can get to it. So if they do a biopsy and put in the clip at the same time, it's one code. But if they do the clip first, and then basically after they do the clip, then they do the biopsy, then you can use them together. So again, watch those notes as well. Okay, so it depends on the order of the procedure. They also talk a little bit about the introduction of the image-guided placement of the breast localization device. If they do those without your biopsies, there are codes for those, and these are not new codes this year. It's just information. This is on page 107 in the professional edition there, just talking about what if they do the placement of that device without actually doing a biopsy at that time. You have separate codes for those as well. And then also with the mastectomies, they did go in and really looked at the definitions there, told us what to do if it's bilateral, looked at the definitions there between a partial, did they use a lymphadenectomy or did they remove the lymphs at the same time? Again, radical. And they also deleted one of the codes in there. If you have used 19304 in the past for subcutaneous mastectomy, because that's not used very often, they did delete that code out this year. So again, just watch your notes, lots of notes in this area. And they remind us too that if the patient is having breast tissue removed for breast size reduction surgery, there's two different codes from there. So that's different than a mastectomy, okay? But again, remember, mastectomy is any removal of tissue of the breast. So when they do a lumpectomy for cancers, they remove tissue, breast tissue, that turns it into a partial mastectomy. Or again, it does show you lumpectomy in the descriptions there of those codes. Now, the other thing that happened in this area is they deleted all of the chest wall tumors because they said those really don't belong here. They need to go over in the musculoskeletal section. So they're moved from here over to your other section there. So that's pretty much it in the integumentary system. Musculoskeletal, a couple of new codes we want to look at. One of is for new codes in the beginning there of the book, and that is at codes 20560, 20561 for needle insertions without injections. And basically those are dry needling or trigger point acupuncture. It's not like regular acupuncture, and they're not actually doing, there actually are codes later on for acupuncture in the back section, but that's not where we're talking about here. This is typically for patients who have pain like neck pain or shoulder pain, and they're putting in some of those. It alleviates the strain sometimes when those muscles are really, really tight, by doing dry needling, by putting the needles in at different levels. Sometimes that can loosen up those really tight muscles. So again, that's just some terms that I found trying to figure out why would they do these insertion of needles. Again, many times they call these dry needling, and many times it is for pain in the neck and the shoulders and the back in that area. And notice with these codes, it does say needle insertion or S. There's insertions without injection. So there's no injections, like there's no anesthetic going on here or anything like that. They're not injecting something in there with that needle. So whether it's one needle, whether it's, any of those kind of things, 5 needles, it doesn't matter. It's the number of muscles. And it's 1 or 2 muscles, it's only used 20560 one time. If it's 3 or more muscles, you use 20561 one time. So again, watch those terms, watch those S's in parentheses. Those can really throw you off if you're not careful with that. So for example, if I was having a discussion with a physician who was doing these services, I would make sure they would know that it's very important for them to tell me the number of muscles they did, because that's really the dividing point between those 2 codes. They also added in some codes for some drug delivery. Now, this is a little different from, like, I know over the years, sometimes like with birth control, they'll put the capsule underneath the skin. This is different than that. These codes starting over at 20700. 20700 is the code number if you're following along in your book. These particular codes have to do with actually creating a drug delivery device. So it's basically got some type of a cement type thing, or cement, however you'd like to say that word, that has some cement, and they basically are including, like, for example, you've got someone with a wound that you're trying to get better. It's maybe a deep wound, and they are going to create this, they take that cement type material along with antibiotic powder type things. They make up these devices, and they actually place this device down in the wound. So you can see that they've got one of these deep, like subfascial. You've got codes that are for intramedullary, and you got codes that are for intra-articular. So it's going directly into that area where they're having problems. So again, this might be someone with a severe wound, a lot of debridement going on. All of these are add-on codes, so be careful with these. There's also a code for removal of these when they go in, or if they have to go in and take those out. And again, because these are all add-on codes, watch your notes. If they do remove them and it's not as a secondary procedure, like not with the debridement, then you've got a different code there to be used, and it guides you to that code in the instructions. And they always tell us the best thing about CPT is that everything is in the book, and sometimes the hardest part about CPT is that everything is in the book. The notes are everywhere, and you really have to be careful with those codes as well. So with your grafting materials, again, as we've talked in the past, your grafting for those are basically grafting like bone marrow, other cartilage, bones, things like that. Almost all the time, if it's autologous, you are going to be able to code those separate, unless there's something in the code description that says it does include the harvesting when performed, then you would not. But other than that, these are always going to be secondary codes. So the codes didn't change here. It's just a matter of reminder. And it also reminds you here about those new codes we looked at over in the 10,000 section, those codes that started with the 1. For the soft tissue grafts and the fat grafting by liposuction. So there's guidance and cross-referencing to those codes as well. As I mentioned to you all ago, they did remove the chest wall tumors, and they moved them over to the section here, and those are over at the 21600, And so again, I'm just kind of flipping through my book as we're talking here today. So these new codes, again, they're not really new codes, but they're in a new location. So they are really new code descriptions. So if you have done any of the excision of the chest wall tumors, these are now over at 21601, 02, and 03. And those do include the ribs. Again, that's why they're deeper than just those in the breast area. So that's why they moved them here. And also if they do plastic reconstruction or do lymphadenectomy at the same time, you have appropriate codes for those. They're not add-on, they're just the level of deepness. What did we actually do? And if we did all of those procedures, it's all going to be one code there. So watch your notes, watch your documentation carefully to make sure you have everything you need there. Moving over to the respiratory section, not a whole lot of stuff in respiratory. The main thing with the respiratory section, it appears that they just kind of cleaned up some of those codes. You'll see some notes, do not report with, and those kind of things. There's several revised codes over in the endoscopy section, and basically they just clean them up a little bit, like at 31233, which is a nasal sinus endoscopy. They moved the information that is common is going to be in front of the semicolon. Anything that's separate, it's only for that code, is moved after the semicolon. So they just cleaned it up and made sure that the parent code was accurate, and then looked at all of the baby codes or the child codes underneath that as well. So they just kind of changed those, cleaned those up a little bit. Lots of other cleanups in this area. Again, just nothing really big, just kind of making sure that the codes are reading the way they should be. And so you'll see a lot of triangles in this area, and also lots of do not reports. Now, I really am a big believer, and you need to make sure you're reading those do not report notes. What CPT did a few years ago is, instead of giving us that old definition of separate procedure that used to make us crazy because we weren't really sure exactly what to do with that, instead of, with new codes, instead of saying separate procedure, in other words, don't use this code if you do it with these other stuff, instead they give us do not report notes. I love do not report notes because it's very specific. It says do not use this code with these specific codes. And sometimes it'll say anytime, sometimes it'll give you specific times. Like some of them might say when we're performed on the same side or the different side. So watch those and make sure when you're coding those that you're coding them correctly. That's pretty much all we have in the respiratory section, not a lot this year. Cardiovascular, we did have some deleted codes in the pericardium area, which is the very first part of the section there. And in the starts on page 216 if you have a professional edition. In the pericardium, again, you have 4 new codes in that area. They divided out the pericardiocentesis versus the actual drainage. Now, the difference between the centesis, which is a surgical puncture to remove fluid from the pericardium or the area around the heart, instead of just basically removing that fluid. The other ones, the drainage, it says with insertion of an indwelling catheter. The indwelling catheters are left behind, and that's why that makes it very different. And again, you want to look at the notes because some of these are going to be according to the age of the patient. If it's a baby with a congenital cardiac anomaly, or anybody who's got a congenital cardiac anomaly, there's a specific code for that patient. So again, watch your notes. It's not just the age, it's also the fact that you're treating a congenital cardiac anomaly. So that could be many years after birth. And again, just watch the ages there, watch to see what else they did. If they also did a CT guidance, again, there may be a different code. So watch those carefully. In your pacemaker or defibrillator, just some clarification on those because there are different types of pacemakers, different types of defibrillators. Remember, we now have the basic kind of transvenous implantable pacing cardioverter defibrillator. We have the subcutaneous cardioverter defibrillator, and then we also have the implantable one. So again, you want to make sure that you're using the right codes for the type of device that your doctor doctors are installing or inserting into the patient. So a lot of information there. It talks about electrodes versus the actual the battery pack or the pulse generator, just watching those carefully there. And a lot of these too, just like a lot of the insertions of these devices, as well as any kind of a device where they have to program or reconfigure it over time. Remember, there are separate codes back in the medicine section for those reprogramming or testing or evaluating the device. So basically, when they're putting the devices in, they're going to test them then. You don't get to code that elsewhere. So again, you want to watch, make sure you're not over coding anything. Great table on page 218. It does not give us any new information this year, but again, that's really helpful when you're trying to code your pacemaker. On page 219 is where they talk about the device evaluation codes, and again, telling you when you can or cannot use those particular codes there. And again, remember, we do have some category 3 codes that are referred to in this area, different types of pacemakers. So you want to make sure, again, that you're watching those. Category 3 codes are just as valid as codes over here. So if there's a note here in this section that says, if they do it this way, make sure you use like 0580T. That's not a, if you want to, that's not, that basically that's a command. It says here is the right code. You must use those category 3 codes, the ones that end with a T. And I see quite a few of those instructions in this section of the book. So just be real cautious with those. The next section we'll look at is the electrophysiological operative procedures. And these are going to be when you've got surgical treatment of dysrhythmias or arrhythmias there. They basically are doing tissue ablation when they're watching how the electricity is moving to the heart, and they can sometimes get rid of tissue. They can destroy tissue, and that will ease that and actually get rid of the arrhythmia. So again, lots of codes there. There are some codes where the patient can be beating heart, and some where they actually have to put them on cardiopulmonary bypass. So watch the codes, make sure you're using them as appropriate there. So again, watch the codes. Again, deleted codes. They added some of those notes there to help us code those correctly. Then we get over into the valves. In the aortic valve section, there's a lot of notes there reminding us that when they do have the patients on bypass, that you want to make sure you use those correctly. There's a lot of add-on codes for the cardiopulmonary bypass support with those like the TAVR procedures. Basically, a lot of those can be done with beating heart. They don't have to be on cardiopulmonary bypass support, but if you do, make sure you use the add-on codes in this area. They also did some of the similar things and some notes in the mitral valve as well as the tricuspid valve. Again, watch the notes for the category 3 new codes there. So we want to be careful that we're using those correctly. Then we move on over to the aneurysm area. Of course, you can have aneurysms anywhere where the aorta is moving through the body. If it's in the abdomen, you'll call that an abdominal aortic aneurysm. If it's in the chest area, those are thoracic aortic aneurysm. The thoracic aortic aneurysm, we have a couple of new codes starting at 33858, and those are ascending aortic graft. Again, it does include cardiopulmonary bypass as part of that procedure, and it also includes valve suspension if they do that as well. It reminds us in the notes there that sometimes they will have to do something separate if the thoracic aneurysm does involve the aortic arch, and that's where the aorta, if you think about it, there's actually a picture on the page 237 in your code book. But basically, as the aorta goes up and around down into the heart, that's called the aortic arch. And so if your aneurysm does involve the aortic arch, then you might need an additional code there. So again, you want to watch those very carefully to make sure that you're coding them correctly. Also notice here with these 2 new codes, they do talk about the diagnosis there, because it says with 33858, it says for aortic dissection, And then 33859 says for aortic disease other than dissection, like an aneurysm. So again, there can be other things other than aneurysm there. The reason why that they're different is because if you've got someone that's got a dissection, think about the vessel is actually kind of falling apart at that area. That may be pretty weak. They may have to do an additional procedure and shore it up a little bit, maybe put in a little bit of a kind of a, not a mesh, but something like that to strengthen that vessel. So that's usually going to be a little more extensive. Excuse me, the procedure is a little more extensive there. And so we want to make sure that we are coding that as appropriate and giving the doctors credit for those types of procedures that they may have to do there. When we get over to the abdominal aorta repairs, many times those also are going to be aneurysms as well. There's just some notes there about the endografts, making sure we're coding those as well. And so at that area, if you want to look over at 34717, just flipping on over to those particular codes, and I'm looking on about the area of page 246, 247. In that area, lots of instructions on how to code these. When you have what's included, if it's bifurcated, meaning it's branching out, the endograft is branching, there's notes on how to take care of that. When can we code any selective catheterization separately? Those can be pretty extensive procedures, so you just want to go through and review all those notes. There's some pretty good pictures in that part of the book as well. I love the pictures in my CPT book. So even if you guys are using encoders and stuff, we love, TrueCode. And one of the nice things you want to do with TrueCode is click on the pictures. All those pictures are going to be, you're going to see them in there. So I can't wait to get that in, I think next week when the new updates come out, so we can start looking at those and seeing how they look within the system. I like those. So the new codes are at 34717. That's an add-on code there for the endovascular repair of the iliac artery at the time of a endograft placement. And then you got the 34718. And these are out of order, by the way. Remember, not all the codes are going to be in exact order. Again, lots of great pictures there as well. And again, watch all, there's a lot of green in that section, a lot of notes there that say use this with or don't use this together. A lot of things you want to look out for there. Then we're going to go over to 35572, 35572. Wow, that sounded really country. Sorry about that. 35572, the harvesting of the Fempop vein. And just again, notice there, that's one of those, don't use modifier 50. We talked about that already. Then moving over to the Artery Exploration, these are new codes. And actually what they did, this is where you did have existing codes and they felt like they changed the definition enough that it was not good enough just to totally put triangles next to all these codes. These are excision, or excuse me, these are evaluation exploration. So these are patients who might have a trauma and there may be some stuff going on there, and they are doing some exploration of the vessels. So looking around, seeing if anything's going on. Now, again, notice they say not followed by surgical repair. Now, these were very specific to the named arteries, like the brachial artery or the whatever artery it may have been. And they said, we really want to, because sometimes they don't just get into that one artery, they get into several in that area. So we instead changed it to where it's neck, like the carotid or the subclavian, as opposed to upper extremity or lower extremity. So again, you can see some of the vessels named there in the code book. But again, you wouldn't use those when they do additional procedures to fix something. Even if they start off looking around, if they fix something, then you don't want to code it separately. Next thing we'll look at is the intravenous ultrasound, and this is over at 37252. So that's several pages back in our code book. So you're probably hearing me flip my pages here because I like to look at the book as I'm doing these classes. So I want to make sure I don't tell you anything wrong there. Page 291 in the professional edition. And so the intravascular ultrasound services, basically those are, the codes didn't change there, but they really just updated the list because there's so many of these codes that some of them were category 3 codes, they're now category 1 codes, as also, the other thing too. Sometimes they go from one to the other, but again, just watch your notes. There are category 1 and category 3 codes that can be used with the intravascular ultrasound services there. And that's all in that section. Then we move over to the hemic and lymphatic system. Just one little note in that area, and that is that the thoracic lymphadenectomy, basically they just updated the list of codes there. That is an add-on code 38746, and it just reminds us, because they did delete some of those integumentary codes, they replaced them with the 2000 level codes. So they just fixed that. You know, all the times when they change a code, they got to go find it and make sure that they've told you the right thing everywhere that that code might have been listed. All right, moving over into the digestive system, not a whole lot of changes this year. So we're going to go all the way over to 46945, 46945. And so let me get there. And these codes are over in the anal region of the body. So you can see they're toward the back of the code section. And basically that's in the hemorrhoid section. So with your hemorrhoids, you have internal hemorrhoids, you have external hemorrhoids, you have different types. They may be thrombosed, they may do the ligation. There's all different types of ways that they can get rid of or repair those hemorrhoids. So they basically changed some of the definitions to make sure that we are clear that ultrasound, if they do ultrasound or do image guidance, then it shows you with or without image guidance there, and it tells you what codes you can and cannot use together in those areas. And then also there is a new code 46948 is a hemorrhoidectomy by transanal hemorrhoidal dearterialization. So a dearterialization, I wanted to know more about that. I didn't know what that meant by dearterialization. So what they do is they go in and they identify and then they ligate the artery. They use an endoscope, they use ultrasound to kind of look around there as well, and they do identify those and then they get rid of them. They destroy them there. They also might do a mucopexy, which is also there. It says with mucopexy when performed, and basically they do a suture ring to kind of shore it up to kind of help repair if there's a prolapse, to pull it back into place again. And also notice that it does say that to use that code they must do at least 2 or more groups, and there's a nice little note underneath it that says if they only do one group, that you have to use an unlisted procedure code. So again, must be at least 2. So talk to your doctors about their documentation if they're doing this procedure. All right, so a couple other new codes. Again, I'm probably just going to get through most of the surgery, and then I want to make sure we have time for the questions today. So also, if we look over at 49013, 49013, and 49014, those are pre-peritoneal pelvic packing for hemorrhaging and then re-exploration. So this is where the patient, lots of times when they have hemorrhaging and they're looking around, they'll do a laparotomy. They'll do an incision into the abdominal cavity and look around that way. This particular procedure is not making a cut. They're not actually making a laparotomy. We've got codes for that. This is where they're doing a different type of incision in the pelvic area, but it does not go into the abdominal area there. So again, you want to watch those codes there. And it does talk about packing if they need to, local exploration, and then there's also a code for the if they have to go back in again and then remove that packing at that time. So that's just a little different methodology there to be able to take a look and see what's going on after a trauma. Now that's all in the digestive system. Moving on over to the urinary system, actually only one thing at the very back of the urinary system, and that is a note with the prostate procedure. Just to remind us that there are category 3 codes now, and this is with code 53854, and this is with your TRPs, thermal therapy, that kind of stuff. And it just reminds us, if they do a transurethral ablation of malignant prostate tissue by high energy water vapor thermotherapy, you have to use 0582T. So watch carefully for those directions for using those category 3 codes, because I've just showed you a whole bunch of those in just a few minutes of time there. Now, in the male reproductive system, only thing we have there is over at 54640. 54640, that's an orchiopexy. Basically, an orchiopexy there, surgical fixation of the testes. This could be done like basically if you've got a child who the testes don't come down out of the abdomen after birth, they may have to go in there and move the testes down into its proper location. It does show you here, they do that either with an inguinal or scrotal approach. And it used to say with or without hernia repair. And basically you should be able to, if a patient has a hernia, that is totally separate from this, and you can code the hernia separately. It was confusing the way they had this worded in the past. So that's why they fixed it. And then they actually added that scrotal approach as an additional methodology to be able to repair this. Last of our big sections is going to be our nervous section. Not a whole lot there. If you look over at the spinal injection codes, I have a guidance for you there, page 424 in the code book. When you look at that particular note, under the injection, drainage, and aspiration, they're just reminding us there about guidance on when you can code the contrast injections. It's usually included in most of those procedures, but it shows you a long list of when it is included, and basically when you cannot code it separate, because again, they did take away some of the radiology procedures this year because of the fact that they found them to be inclusive in the surgery codes themselves. And so we didn't need them anymore. So we do have some new and revised codes in that area. We've got some revised codes at the spinal punctures, like a lumbar puncture. They divided those into diagnostic and therapeutic, and whether they're using guidance like fluoroscopic or CT guidance. They took the existing codes, divided them out so you can code those as appropriate there. Okay, the nerve blocks, the somatic nerves, they went in and did some work on those codes, whether they are injecting, like doing a pain type of treatment, or if they are doing a denervation, basically. So those codes have been revised in the instruction notes there. A lot of the revisions of codes start on page 436 under the somatic nerves. And again, a lot of these are talking about the injections of a steroid or an anesthetic agent, and they are very specific to the name of those somatic or nerves. Now, they also added in a great little table on page 437 that might help you with making sure you're coding those. And it talks about the different nerve branches, the plexus nerve, the genicular nerve branches, and how many injections they do. So that's a nice little table there to assist us in making sure we're coding correctly. Now, they did the same thing with the destruction, and that's over, again, somatic nerves, a couple of new codes, 64624 and 64625, and those are just additional codes for destruction by a neurolytic agent, and that's going to be of the genicular nerve branches, or you've got the radiofrequency ablation of the nerves innervating the sacroiliac joint, again, with guidance there. So again, fluoroscopy codes fluoroscopy is included with many of those. And again, that's another place where they did delete out the radiology codes that could have been used with them because now they're included there. Lastly, in the surgery section of the eye and the ear, they did do some changes over at the area with the extracapsular cataract extractions. When you've got patients that do have removal, basically, if you look over at 66711, 66711 is actually the page before the extracapsular extraction. And that is if they just do the cyclophotocoagulation without actual removal of the lens. If it's done by itself, it's over here. If it's done in conjunction with the cataract extraction codes, you've got the new codes. 66987 is basically your standard extracapsular cataract removal all at the same time, but also doing the endoscopic photocoagulation at the same time. So again, watch those codes. And again, remember, there are times in this area to watch for those category 3 codes as well. Now, because we have just got a little bit of time left today, I do have information here about your radiology and the rest of the codes that you have in your handouts. But I want to check first while we've got about 7 minutes left before I move on to these other sections. I'm just going to stop and ask Sharon if we do have any questions, because I certainly want to try to get to your questions today if you have any on anything I've gone through so far. Sharon?
Yes, thank you, Karen. So I think there were a few questions related to undermining. So someone asked what the definition of extensive undermining is, and someone else said, isn't it also a method of separating skin from underlying structures to facilitate a repair of a large or gaping wound?
Yeah, and that's great because in CPT, it doesn't actually give you a definition. So I was going through and trying to find that. I looked in the CPT coders, the changes, and they just talk about the undermining, but it doesn't really talk about it from there as far as exactly what the doctor's doing. So it's not really clear if the actual the actual wound is opening up and they're trying to do it there, or if they're actually doing undermining. And basically, the undermining there, it just says like extensive is defined as a distance greater than or equal to the maximum width of the defect, and you got to measure that. So you kind of have to look at their definition there. So when I first read it, it did appear that they're talking about the doctor doing the undermining. So I agree with the person who just said that. That's what I thought as well. And then I started trying to go out and find out exactly what it was, and I found the other definition of when the wound is actually opened, and that's actually undermined itself. So there is actually two different definitions there, and I think we're going to need to ask CPT about that and look to see, like with the CPT assistant articles coming out, to be real clear on that, because you can see it talks about the distance, but it doesn't actually say the doctor does this or the wound is this. So I think there's a little bit of confusion there. It's exactly what they mean and how we're going to use that. So thank you for bringing that up, because again, I had that same kind of thing, is what exactly are they talking about here? Is the wound itself doing that? And again, you've got the measurement there, but it shows the line of closure, and it's making it more difficult to do that. So I don't have an answer for you there, but it's certainly something I'm glad you brought up, because we do want to make sure that we are understanding their intent, and that's what we're still trying to figure out. So thank you for those.
Thanks, Karen. There were a few other questions about the CPT codes that you reference on the slides. A lot of them begin with X, and people were just wondering what that meant. And some
Yeah, so basically sometimes I'll put those on there in my handouts just so you can have a guidance to get to that, basically because all the codes are copyright protected. I don't want to get in trouble. We don't want to get in any trouble with the AMA. These are their codes and they're copyright protected. Sometimes I'll just put them there to give you a guidance. So if I put an X in the front of it, if like here on the screen now, I'm in the radiology section, that's obviously going to be a 7. So you can figure it out. And I should have explained that to the beginning. I'm sorry. I was so excited about getting into these codes, but basically it's just for you to be able to go back to your code book and go, okay, where is that code she was referencing? Because they're all over the place. So that's what I do. I sometimes will put an X there, just so I can put a part of a code there so you can find it when you go back and try to take all this stuff I'm telling you and try to put it into action. So, yep.
Got it. I think that answers everybody's question. Thank you.
Awesome.
Questions at this point?
Okay, great. Well, I'm going to go on past radiology and we've got a couple minutes left. I want to go over into the medicine section, just briefly go through those before we end up today. They always have a couple of new vaccines. Some of these are not actually on the market yet, but you'll see a couple of vaccines there. There's a couple of codes in the biofeedback area. Training, basically someone who's had a trauma or issues with the perianal muscles, they're doing actually biofeedback training to help that work better. Those are by time, 15 minutes in each additional 15 minutes. In the ophthalmoscopy area, the eye area there, we have a couple of extended ophthalmoscopies, and again, these are going to be treated by the actual diagnosis they're treating. Like one of them is usually for retinal tears or detachment, and the other one is typically for glaucoma or tumors. And that's the main stuff there. In the cardiovascular area, again, every year it seems like we're getting more and more instructional notes on the wearable devices. We get more of them. We're having more and more where patients can actually wear stuff home and we can monitor it remotely, which is amazingly awesome in my opinion, but we got to make sure we're coding them correctly so we can get credit for those. We also, there at the bottom of the page, I think are some interesting codes, and those are actually at 93784. See what I did there, that very bottom part, 93784 through 93790. So that's how you interpret my weird thing here. But basically, those are for ambulatory blood pressure monitoring. One of the codes is actually for setting the patient up, and the other one is for they just really try to look at the report generating software. So there's lots of different methodologies of actually being able to read those. So I'm going to look at those codes. I want to give you the right information there. So I'm looking at 93784, 937. Hang on a second. Of course, it's not right where I put my finger in the code book. So yeah, 93784. These are all revised codes there, and they are by the different ambulatory blood pressure monitoring using report generating software, automated, and again, you can see that for 24 hours, recording only, scanning analysis, and then review with interpretation. So basically just kind of cleaned up those codes a little bit there. Not a whole lot there in the other cardiovascular. In the pulmonary testing, again, just tried a couple of things with some new EEGs. We probably do want to take a look at the EEG area, and that's at 95813. If you look over at the 95, actually all this information starts over the special EEG test over on page 712 in the code book. A lot of definitions there. These are for long-term where they're actually doing EEGs, either monitored or, where they're we're wearing them home. There's a long-term EEG setup now. The 95700 is right there. And again, several new codes for those EEGs with videos, lots of stuff going on, page 716, 717 there as well. Here we go. There's the information I knew I was talking about. There you go. So basically there's 4 new codes, 23 new codes, 4 codes deleted, new heading, new table, and then you have all those, and they are all time-based. So you want to watch those if you're doing any kind of EEG type services for your patients. I think that's it. I think that's some good stuff there. Again, there are quite a few. Oh, if you are doing your category 2 codes, there are some new breakdowns on the A1Cs. That's very important this year. So especially those of you on the physician side, take a look at those category 2 codes for the A1Cs. That's going to be real important, the way they divided those out for HEDIS measuring, for example. And then quite a few new category 3 codes that we've been talking about already today. Well, I think I've made it. Yep, it's exactly an hour later. So we made it through as much as we could in the time today. And again, our point here was just to try to start you thinking about what those changes would be, for you to have time to get, with your encoder, to look in your code books and really get ready for those changes that do take effect on January 1st. So thanks so much for being with us today. Just as a reminder, if you want to get a CE credit, you need to complete the evaluation. So I'm going to give you a moment to write that down. And Sharon, I'm going to turn it back over to you if there's anything else you need to tell them. Thanks, everyone.
Thank you, Karen. That was awesome. Yeah, no, I think Karen covered everything. This is the link that you can use to access your evaluation and download your CEU certificate. But again, an email will be coming out first thing tomorrow morning, and it will have this link. It will also have a link to the recording. So if you know anyone that wanted to join today and was not able to, they can always view the webinar on demand, and they can still earn their AHEMA CEU. So thank you, everyone, for your time and for your attention, and we look forward to seeing you on another webinar. Have a great afternoon.